Jenny Skiba, who's going to tell us the details about how this works.
Hello, thank you for joining this Zoom video conference of the Scrutiny Committee. I am the Democratic Services Officer for this meeting, and I'm assisted by my colleague Kate Sheldon, who is the host of the virtual meeting. We will proceed to introductions and housekeeping in a moment, but just a couple of points to note. This meeting is a public meeting, and in alignment with the new regulations which permit meetings to be held by remote means, will be live streamed for the public to view. Sheffield Live are also intending to broadcast parts of the meeting. To make the meeting run as smooth as possible, can I please ask that participants in the virtual meeting room to leave your microphone on mute when you are not speaking. When you wish to speak, please raise your hand to the camera, only unmute when the chair indicates that you can speak. If we have any public questions or speakers, the meeting host will bring in speakers in the virtual meeting room at the appropriate time. Once you have spoken for the allotted time, the host will then return you to the virtual public gallery. If at any time any member loses the ability to hear or be heard, they must alert the chair or host as soon as possible. You may see members looking to the left and right of their screens. This is because they may be looking at an additional screen or device containing the agenda papers, not because they are distracted. I will now hand over to the chair of the meeting. Thank you.
Sorry, I thought I had clicked on that. Do we have any apologies for absence, please?
Yes, Chair, we've got apologies from councillors Louis Stagnall, Gary Weatherall and Gail Smith, and we've got substitutes for councillors Alan Law, Julie Grocott and Sue Auckland retrospectively. Okay,
thank you for that. We don't have any items on the agenda which require the exclusion of the press. Doesn't work this way anyhow, does it? Do we have any declarations of interest?
Chair.
Yes, Councillor Drabble.
Thank you, Chair. I just wanted to apologise to the committee that I'm going to have to leave early today at about 10 to 5, I'm afraid. I'm just checking you got my apologies on that.
Yes, I did. Thank you very much.
Right, thank you, and apologies to the committee.
Okay, thank you. We haven't done our introductions yet, so I'm going to do that, and I'll call out your names in the order I can see you on my screen. So first of all, to everybody, I'm Councillor Kate MacDonald, and I'm going to be chairing this meeting. Adam, Councillor Hurst. Unmute yourself, please, Adam. Right. Adam, could you yes, thank you.
Right, so yeah, Adam Hurst, we're Councillor for West Ecclesfield.
Lucy.
Hi, Lucy Davis, Chief Officer of Health Watch Sheffield, citizen voice around health and social care.
Thank you. Vic.
Hello, Councillor Vic Bowden, Councillor for East Ecclesfield.
Julie.
Good afternoon, everyone. Councillor Julie Grocott from Stocksbridge and Upper One, substitute member for today.
Angela.
Councillor Angela Argento from Broomhill and Sharrowvale.
Emily.
Emily Stanbrook-Shaw, Policy and Improvement Officer. I support the committee.
Jane. Jane, could you unmute, please?
Yeah, sorry. Councillor Jane Dunn, Southey Ward.
Sue.
Councillor Smolston for Fulwood. We've got two Sues, Kate.
Oh, have we? Oh, sorry. Oh, yeah, I shall have to use your full titles. Okay. Councillor Alan Law, please. Alan.
Alan Law, fifth part.
Nicola.
I'm Nicola Shearston. I'm Head of Commissioning for Prevention and Early Help Services.
Talib.
Councillor Talib Hussain, Councillor for Bangry Ward.
Steve. Steve, could you? Yeah, thank you.
Good afternoon, Councillor Steve Harris, Graves Park Ward, and I'm Deputy Chair of this group.
Joe.
Hi, Jo Horrobin, Head of Adult Social Care Commissioning.
Sue Auckland.
Thank you. I'm Councillor Sue Auckland. I'm a councillor for Groves Park Ward. and I'm here today as substitute for Gail Smith, who's put in her apologies.
Okay, George, please.
Thank you, Chair. I'm George Knowles-Hammond. I'm the Council of Hillsborough and Cabinet Member for Health and Social Care.
Mike.
It's Councillor Mike Drabble, elected member for Richmond.
John.
John Doyle, Director of Strategy and Commissioning at the City Council.
Martin.
Councillor Martin Phipps, Councillor for City Ward.
I can see two other people down the bottom of my Sarah.
Hi, Sarah Story, Interim Director of Adults Health and Social Care at the Council.
Abdul, could you unmute, please?
Hello, apologies, Chair. Just trying to get my technology right again.
Okay, and I've got, we've already, Kate Sheldon, did you want to introduce yourself? No.
So I'm Kate Sheldon, Member Support and Civic Officer. I'm hosting the meeting.
Thank you. Okay, welcome everybody. We've got, first of all, we're going to go on to the minutes of the previous meeting, but I will want to say a few words about how we're going to handle the meeting, given that how the situation with COVID has moved on very quickly since these papers were commissioned and actually circulated as well. So let's kick off then with the minutes of the previous meeting. First of all, can I take them as a correct record? Accurate record? Yeah, everybody happy? I'm just quickly going to go through them page at a time for any matters arising. Please indicate if you'd like to raise anything. So I'm using the page numbers in the pack. So page 9, 10. Emily, did you want to mention that we got a response to the financial questions and so on?
Yeah, the questions that were the public questions that were asked during the meeting, the majority of them were answered during the meeting and in the discussion, but the ones at section 3 on page 11 around finance weren't. So we got a response from the Care Trust that's been sent to the questioner, and I'll circulate to members of the committee as well.
Thank you. Anything else, page 11? 12, 13, 14, 15, 16, 17, 18. Can I just sort of make a comment on 7.6D? It might come up later on, but just to mention that, in fact, instead of the report coming back in 6 months, it's likely to be 7 months, because our meeting clashes with the Trust's board meetings. That's just an administrative thing, so I just wanted to mention that now. Okay, thank you. As far as I'm aware, we don't have any public questions. No. Okay, thank you. And now on to the substance of the meeting. Just to say that obviously it's really important that we focus on the longer term issues. But in introducing the paper, I wondered whether or not it would be really helpful. Don't know who's going to introduce the paper. Is it you, Joe, that's going to introduce it? Or is it John? Who's going to introduce the paper, please? Oh, Joe. Okay, in introducing it, it'd just be really helpful if you could just give us a quick update on the state of readiness in relation to the care home sector and so on, because that'd be at the front of everybody's minds today, and it'd be really helpful if we could just sort of address that right away. Thank you, Joe.
Yeah. Okay. The paper is actually made up of 3 parts, and the third part of that goes into some detail about the support that's been provided to the care home sector in particular, although we have been supporting all of the care and support sectors in the city in the first, if you like, the first phase of pandemic. In terms of our readiness at this stage, I was reflecting on this earlier because I held a meeting of care home owners this morning. We now have a regular monthly forum on top of the care home manager meetings that are organised by the CCG. And we reflected in that session today actually on the position that we're at. Care homes are very nervous, but they also feel, and I feel as head of commissioning, having worked very closely with this sector throughout a really traumatic period, that actually we are in a very different position and we are much more ready than we could ever have been in March. We understand now how the virus works in care homes and in the community. So we have weekly testing for all care home staff and residents in the city. There are occasional examples where that doesn't go exactly as planned, but that is a priority for the city and it is prioritised. And actually, we are seeing the impact of that in enabling us to keep the number of outbreaks, with an outbreak being 2 cases or more in a home, really under control over the last few weeks. So as things stand today, we have probably 3 outbreaks which we're aware of, which is 2 or more cases of either resident or staff members in the city. And then we have a very small number of single incidences in other homes. And they have all been picked up as through asymptomatic regular testing. So about a month ago, we were very aware that the R rate was increasing, that there were some communities in the city where that we were seeing that begin to the infection become more prevalent, and there were a number of outbreaks in care homes, which put us all back on our guard. Not that we'd let that down. Actually, that plateaued since that point. It actually reduced the number of infections, reduced and plateaued, and has remained. I would cautiously say, because this is an emerging situation, that actually we have held that. Providers have held those levels. So what we're seeing in homes is, generally, with a very small number of exceptions, is an infection crops up. It's come in through community transmission, and we identify it quickly. The proper processes are followed. The right controls are in place. The right PPE is being used, and we're not seeing that have the catastrophic impact that it did in the first stage of the pandemic. So other key things that are resolved now and which are solid now is the supply of PPE, which, as you all know, I'm sure, was a huge challenge. In Sheffield, we sourced a lot ourselves through our own initiatives, really, and through just hard graft, working with providers. And my team drove it around the city in kind of 4-day supply chunks to providers where their own supplies failed. We now have quite a robust supply chain, and we have been able to store PPE as well in order to give ourselves greater business continuity comfort with that regard. And the key thing as well is that providers understand how to use it, why it matters how they use it, and they know where to get it, they know they can get it, and they know how to dispose of it. So that is another key change. The other thing I want to cite is the investment of the IPC grant, which we've had into care homes. That's just over £900 per care home resident has gone in from that grant since May up to the end of September. And most of that has been spent by providers. There are very, very few exceptions where a provider has said, I don't know how I can spend this. And we've worked really hard with providers to make sure that they did spend that and they spent it effectively. So that has also had a significant impact. That's been a significant investment for quite a lot of homes, for homes in the city. So that is a major shift, I think, as well. We also have a well-established inbox, which is monitored for care homes and any other providers to contact us during normal working hours. And they'll get a quick response, a monitored response to queries that they raise. We've got an integrated approach with the CCG. and we work very closely with colleagues in adult social care in Sarah Story's teams as well. So we have the option of supporting homes or providers who are struggling with staffing issues through providing care workers support to those organisations. And we have our out of hours service for any provider that is concerned or family member who is concerned out of hours about what's happening in a home. So we have a sort of a tried and tested structure around our COVID response now. We know how we would administer any additional support that might become necessary into financial terms, and we understand how to the best way to administer the new round of the infection control grant that was announced a couple of weeks ago. So, and we have a very robust agreement and shared principles and values with our colleagues at the teaching hospitals and the CCG around discharge from hospital. So we're working really closely with regular several meetings a week. I have, and many of my colleagues have more than that, with our colleagues across the system. So actually a much clearer, more robust understanding. And providers are not looking forward to the next 6 months, but they are, I would say, perhaps surprisingly calm given the stresses that they have experienced. But I think they also know how much they've learnt. So that would be a kind of a summary. Is that helpful to?
Thank you very much for that, Jo. Now, I've got Steve and I've got Jane, but I'd just like to say that bear in mind, this is your opportunity our opportunity to think about the longer term as well today. And obviously the situation has been accelerated, and the need for us to be looking at the whole strategic picture of adult social care because of COVID, and I'm guessing that's going to continue. So I'm going to open it up. I've got two already. I've got Jane and I've got and Angela now as well, and Steve, for questions and or comments. So Jane, you're first on my list.
Thank you, and thank you, Jo, for all the work you've been doing. And you can see actually how much work in the last 6 months has taken place. I just want to ask these questions. I'm asking on behalf of my constituents because they actually asked me to ask a couple of these. You've mentioned on page 28 of the report about staffing support in case of care homes where there's not enough staff. So what plans have we got in place when we're using agency staff that they're not spreading infection between multiple homes? Because that is one of the things. We understand the pressures and it has to, but what have we learned and what have we done from that on that? What also, are there surge plans to make sure that care home residents, when they're discharged and they could be potential COVID-19, are they in spread rooms so they don't spread the infection? So is that across the board, and what are we doing there? And I'll come back, I've got another one which is about infection control and just about training. Is everybody now, like trained? Are we keeping the record of, like the record of that? And how often does the GP visit? Every care home has it. How often is a GP visiting? Because these pressures will come as winter comes. We have these pressures, but with COVID, I think it's just so we can see that across the city we've got fairness, as well. So what are we doing as a council on that? Thank you.
So who wants
a lot of questions, but quite short.
so who wants to take those? Is it Jo? Yes.
I'm happy to take those. So first of all was the use of agency staff, and I think there's I think you've picked that up from the report in the context of us and the comments that I made earlier actually about us being in a position to support with additional staff. Now, one of the challenges has been how to get testing for agency staff, and we are very clear and work very closely with providers that any staff that are fielded to that provider, whether it be from ourselves or from an agency, must be incorporated into their testing regime and must be tested alongside all of their other staff in the same way and treated as within the same cohort. So we are very clear on that. And actually, you know, we are looking to minimise that kind of intervention through care homes proactively thinking through their staffing challenges and avoiding the use of that wherever possible, because it's we know, don't we, it's better practice not to have too many changes of faces, but we also know there's a reality. So given that a number of providers, many of our providers have sadly got very high vacancies at the moment, we are asking them to think about how they can use that something like the Infection Control Fund monies to help to maintain staffing levels so that they don't need to access agency or indeed our support. So our support is a really sort of really for emergency crisis use and must be tested alongside the rest of the care home staff. Okay, surge plans was the next thing that you asked us about, and this is we have I've been talking to colleagues at the teaching hospitals about this today. We work very closely with the hospital. We want to avoid with the hospital hospital discharge of anybody who still tests positive, who is testing positive. So we maintain that commitment as a system to avoiding, where possible, COVID positive discharge, people being positive at the point of discharge. What we have to acknowledge is that there may come a time where the hospital is faced with that challenge, where the pressure in the hospital is such that we need to look at, we need to have alternatives, and we need to have planned for that. We currently have very high vacancies in care homes in the city, but our first principle is home first. So actually, how do we help somebody to support somebody to go back to home, wherever that might be, with the right support? Now, in the case of that being a care home, we're currently working with CQC to ensure we have the right availability of care homes that CQC will designate to receive COVID positive hospital discharge patients. Now, we don't think that we're not expecting large numbers of these, and we're working with CQC to find, you know, a sensible solution that manages risk and also keeps the person's, you know, needs, wants, wishes at the centre of the discharge process. So that's the my response on surge plans. Sarah might have other things she wants to chip in. Do you want to add anything, Sarah, on that?
Yeah, so the Department of Health and Social Care wrote to directors of adult services and chief executives this week and asked us by Friday to nominate to CQC, the Care Quality Commission, at least one provision that they could then inspect and, if you like, quality assure as having the appropriate levels of infection prevention and control standards that they could safely support individuals who are discharged from hospital if they are positive. We have taken a view very quickly in Sheffield that our aspiration would be that every care home in the city, we ought to be supporting them all to work to those standards, because it'll be the same set of standards, the same things that those homes should be doing to support their residents and staff if they have a permanent resident who contracts the virus or a staff member. So we very definitely want to make sure that we are really clear on what those standards are and that we support every provider to reach them and meet them. And in that way, we hope that any individual who comes from a care home into hospital can be supported to go back home again as soon as possible. But again, the key principles that we agreed in Sheffield as a health and social care system, which were to take decisions on an individual case-by-case basis based on the principles of home first, and to understand the situation of each individual and the situation of the setting they potentially be discharged to, rather than apply blanket rules and processes. That remains, and we're really committed to those sets of principles. So we will comply with the request from the Department of Health and Social Care to get that name through to CQC by Friday, but most importantly, we want all homes to be working to those standards.
Yeah, thank you, Sarah. There was a further question about IPC training. So yes, we have got a robust IPC training offer and PPE training offer. The CCG have led on that, so colleagues at the CCG lead on that, and where we pick up any concerns from providers as commissioners and contracts officers, we liaise really closely with CCG to pick up on that and to be really proactive. In terms of the way that is recorded, each home will have to be recording the training that they have accessed, and I'm sure that the CCG similarly have got a log of the access to that training. But off the top of my head, I can't be absolutely specific about that, but it's something that I can check. And your final question was about GP visits and the role of primary care in care homes. I'm going to be completely honest and say I'm not absolutely certain what the arrangements are for GP visits into homes in terms of number of visits, etc. But I know that we are working closely with primary care to ensure that the health needs, be they COVID related or more likely, hopefully otherwise, that they are quickly identified and the right support is given. And this morning at the Care Home Provider Forum, we had a great presentation from a colleague seconded from the teaching hospitals to the CCG, who is leading on training that is specifically about recognising early signs of deterioration and being proactive and giving care homes the kind of an assessment tool and the language and the script almost to use with colleagues in primary care to ensure that needs and concerns are escalated quickly and appropriately, and that the right actions are followed through. So in terms of technically what is contracted for, I'll need to check that, but I think, and I can get back to you on that. I'm certainly not fielding concerns about that today from providers themselves, and it has in the past been a concern for providers, but I haven't had concerns fielded today, which is positive. Okay, I think I've answered the queries.
I've muted myself, I've taken my own advice. So I've got you, Lucy, as well. Next, Steve, please.
Thank you, Chair. Kate, can I just clarify? Are we? We seem to be straying onto the report. Are we actually asking questions on the report now?
Well, I personally, I mean, it's very difficult, and I'm being a bit indulgent. I did try to remind you at the beginning that this is really an opportunity to comment on the big strategic picture. But I'm also sort of sympathetic that because of the fast changing situation, the odd other question might slip up. Well, Councillor Dunn's taking full advantage of that.
All right.
But seriously, Steve, it would be, if you have any really burning questions, I'm not going to stop you asking them. But this is the purpose of the meeting. Actually, is to comment on the proposals to do the adult social care review. So you need to make your own mind up about that, Steve.
Okay. Well, I did have one question to Joe, and I believe you in the first part of what you said, you talked about I believe infection rates in care homes plateauing, but my understanding is that they plateaued according to well, they plateaued in August, didn't they? But then, according to the dashboard, throughout September, there was again a peak. So I'm just wondering at what point you're saying they plateaued.
I think so. There is variation day by day, week by week. But I think what I was referring to is that what we have seen is a number of occasions where we have seen a spike, and we've started to think, is this a sort of a trajectory that's going to continue in the way that we saw in the first stages of the pandemic at the end of March and early April. And what we haven't seen is that we've seen that has been a spike, and then we have seen generally things get back under control, and most, not all, but most of what we are picking up is the asymptomatic, one or two cases in a home, rather than a kind of escalating out of control picture.
Okay, Steve, did you want to make a comment on the report or ask questions about the report as well?
Yes, please. I've got a number of
Okay.
questions on the report. Do you want me to take them now?
Yes, sure.
Take them now. Okay. Right. And I'll try as best to refer to the pages. So on page 20 of the agenda pack, the paragraph talks about, it starts off, the work of operational commissioning is to ensure that these principles are demonstrated in care homes and that care and support provision in Sheffield, and then in brackets, including for self-funders, supports people as far as possible to be safe and well. But I can't see through the report any further specific mention of self-funders in the rest of the report. And as we know, for a lot of care home providers, self-funded residents make up the lion's share of their business. So the 5% increase that was approved in the Cabinet report in March doesn't actually apply to those self-funders. So it would be useful to see some data on the self-funders in the city. What we as the council can do in order to minimise the impact of the effects of the fallout of COVID on their on their business, so to speak. Having to make having costs to meet without having to, we're trying not to increase the fees in order to pay for that. Do you want? Can I go on to my next question, Kate?
Yeah, go on. Yes.
Yeah, because I've got a number of questions, if I may. I think a general question about the report. It's quite clear that we weren't ready for the impact of COVID on elderly people's care homes when the peak hit us from April time. And I think that what we as a committee we want is reassurance that we are ready now, given what we know. On page 21, the paragraph, the section on commissioning priorities, paragraph 3, Roman numeral 3, talks about support for any market exits, contraction minimises negative impact, optimises any suitable opportunities for insourcing of residential care and avoids cumulative, etc. Now, my understanding is the current sustainability strategy is market diversity to spread the risk. And I believe that we've, over recent years, we have actually increased providers. I think that initially there were about 7. We now have 40 something, for the reason that it's better spread of the risk. So I'm just wondering, why does there appear to be this change in direction in terms of the strategy, the current strategy pre-COVID? Could I ask the specific question on how many providers does the council currently commission social care services from?
Can I just clarify, Steve, can I clarify, do you mean both residential and social care? Sorry,
yeah,
if that's possible, residential and domiciliary.
If we could have a split, yeah, if it's possible to have a split of the two. I know we're talking principally about care homes, but I need to get a feel for how many providers we are. How many providers we commission to, if you know, going forward, we're trying to minimise the risk should particular providers have to go under or, you know, pull out of the market. What was I going to say? Now we know the council's overall finances are impacted by the you know, the pressures in social care. Latest is it's going to be 88 million out of the overall council budget gap, 108 million before savings over the next 4 years. So on that, my previous question, does the service have the capacity or the resources to absorb the impact in-house should a significant number of providers pull out of the market? Moving on, is it correct to say that the balance of risk has changed? Would it be fair to say that there's a continued deliberate shift towards home care? Sorry, it would be fair to say, I think there's been a continued deliberate towards home care over several years to support people living more independently. But is it right to say that there is a shift away from the home care market into different types of care, perhaps from residential to domiciliary or unofficial family care, for example, a result of people's individual reservations about the safety of care homes? And I think it's my final question is on page 22, the section on care home market and risk management. I understand that there have been, as at the 9th of October, 361 cumulative deaths in Sheffield care homes. And I just wondered how and to what extent might evidence been drawn from research on COVID-19 deaths in UK care homes that have been carried out by University of Sheffield jointly with a number of other universities led by Lancaster universities that looked at this, because it was one of those gaps that SAGE highlighted some time back, and hence this piece of research. Because Sheffield University is part of this piece of work, I wonder whether we're tapping into that that piece of research. That wasn't my final question. My final question is also in the care home market and risk management section. I'm surprised that there isn't more emphasis on workforce retention and recruitment. I'd like to see what current evidence is on retention, because we know that attrition from the workforce of both new and experienced staff, COVID burnout, as we enter a second wave, could actually be disastrous for us. So I just wondered whether there's any evidence on retention. Thank you, Chair. I think that's it.
Okay, a number of questions there, Joe. A lot of them are sort of, if they're too detailed, then you can let Steve have a response later on. So I think the point about little emphasis about self-funders is a broader issue as well, in terms of perhaps that's one of the comments, a comment as opposed to, you know, a question that we might want to get feedback from the committee on. So comment on readiness for the impact of COVID, and you've reassured us about that. And some questions about the insourcing of residential care, some questions about providers, how many providers we commission, and some issues about the shifting models of care as well.
Yeah.
Okay, are you wanting to take those questions, or does anybody else?
I'm happy to take those questions. They feel like they're in my remit. I'm happy to be interrupted by a colleague.
Off you go then.
Okay.
And just bear in mind, we've got a number of other people as well who
yeah, I'll be really quick.
indicated. Thank you.
Okay, so thank you for highlighting that self-funders don't sort of don't major in the paper, or don't come across strongly in the paper, and reflecting on that as you were talking, I think that is partly because most of our approaches, bar the 5%, have applied to all providers, regardless of whether they are self-funder focused providers or mixed economy providers or just local authority providers. So we offered additional exceptional costs to all types of provider, regardless of who they were supporting, and the infection control grant, plus all of our additional support. We have also fielded support staff to providers which are self-funder. So perhaps it's not clear in the report, but actually everything bar the 5% uplift, which was for a sort of a small number of months early on, has been applied equally across all types of provision, and that reflects our duty to support all residents and all provision. I do believe that we are as ready as it is possible to be for something which we don't fully know the shape of yet. I think we are as ready as we could be in terms of the way we work across the system and the way we've worked with homes. And the feedback from homes is that they feel very supported by us. By and large, we've had a lot of contact from homes eager to tell us, or to tell Julie Dorr, or to tell Charlie that they have felt very supported by us. So I think we go into this second phase with very much stronger relationships and better understanding. In terms of the support for exits from the market, we're working very hard with the market to avoid any unmanaged exits or multiple exits that would put pressure on us and our resources to respond, but also on other providers and of course on vulnerable residents. In the context of the numbers, then I can tell you that we have about 40 active home care providers on our framework, and that might be that jump from 7 to a higher number that you suggested, Councillor Iris. So that we have about 40 providers, and that diversity has served us well and remains the case. We continue to work with all of those providers. No plans at the current time to reduce that. In terms of the number of care homes, we have 111 care homes in the city, 78 of which are older people's focused care homes. We don't have a framework approach for that. We spot purchase with homes based on people's individual needs, wants, and where they want to be in the city and what works for them. So we don't have a framework, but we are working actively with all 111 care homes at the current time. In terms of capacity to absorb exit costs, that is something that we are looking at. As I say, the trick for me is that we don't have unmanaged exits. It's unmanaged exits that cost money. Where a provider is supported early on enough to make the right decision and is supported to execute that well over a minimum of 3 months is the preference that we encourage providers to work with us over, then it doesn't need to have huge impact for us. But you are right that if we were to face multiple closures or providers who felt that they had to exit more quickly, then yes, we would have to look at what the cost of that was. But we would do that on an open book basis and within the bounds of state aid framework. In terms of the shift away from care homes as a preference, yes, we are seeing that. We are seeing that, I think, in terms of public perception. We haven't seen a sort of a bounce back in terms of referrals and placements, particularly not one that we could call a trend, either in the self-funder market or in our own placements. The risk assessment, I will check with my team how plugged in we are to the work that Sheffield University is doing. I am aware of it, and I will just check that we are optimising that. We are certainly working really closely with colleagues in public health and CCG, and we are kind of trying to keep track of the huge quantity of research that's coming through at the moment. So I'll check that that's on our watch list, and we're engaged with that. Workforce and retention. We're seeing, I'm not hearing from staff, from care homes, they're not telling us that they have staffing issues. I think partly because they have such high vacancies where there is a level of turnover, of attrition, if you like, or, you know, people choosing to leave, they're actually able to absorb that because they don't have the number of residents that they have previously had. So some homes are running at 50% vacancies. They will be able to absorb some changes in staffing. We are sending them a lot of information about support for staff that that they can access. And I just had the Home Care Provider Forum, some feedback from them as well. And actually recruitment the recruitment pipeline is pretty positive. So, and that may of course reflect the fact that sadly, there are more people in, you know, unemployed and looking for work. Our challenge is to make sure we optimise that and bring great people in to a profession they hadn't considered. And that's what we're looking to do. We're working with Skills for Care on that as well.
Okay, thank you. Steve, okay? Okay,
Sorry.
Steve, you happy
Yes,
with us?
thank you for that. On the unmute. Thank you for that. Yeah, thank Joe. Thank you.
Okay, Sue Alston, Councillor Sue Alston.
Thank you, Chair. I've got 3 questions about on the report. My first question goes back to something Steve was asking, which is on page 21, the little 3, about the suitable opportunities for insourcing of residential care. And I just wondered whether somebody could actually explain what they actually mean by that, because to be honest, my reading of that is we're going out looking for care homes we can take over very quickly, maybe with a view to, I don't know, running them completely from the council. Is that what we're talking about? Or are we actually just talking about support when a care home is struggling and to help it manage an exit? Because the way that is written, it actually looks to me like the council is going out saying, right, we're going to become a big care home provider, we're going to take over as many care homes as possible. So I just wonder whether you could actually explain that wording better for me.
Yeah.
My other 2 questions are on page 23. There's a statement that just says too many people are in care homes. And I just would like some sort of explanation of understanding of why we think there are too many people. I mean, whose opinion? I do worry that people are often put off going in care homes, and I think that is often probably more true now given what's happened over the past few months than at any time. And I think we, as a sort of a service overall, we should avoid the idea that people should stay in their own homes, even when actually that isn't the best place. Either because it's putting a huge burden on family carers. You know, I'm thinking about the elderly partner looking after somebody with dementia and struggling, but having such a fear of care homes that actually they keep on struggling. So actually keeping someone in their own home isn't, in my view, always the best option. So that's my second question. And my third one is on page 26, which is about the consultation. So I had a look at the consultation myself, and I did it yesterday. It's really, I don't think I came away very enlightened by doing it. Most of the questions you couldn't argue with, you know, it's a bit like, would you like to drown a puppy, yes or no? But what I would like to know is who has been involved in the consultation? Have you engaged with the relevant sort of people in the voluntary sector, carers organisations, etc.? Have you looked at other groups and organisations, bodies that represent the care sector, sort of from a business point of view, as well as members of the general public, you know, publicising it? How have you publicised it? Those are my questions, Chair.
Thank you. I was going to give George an opportunity, Councillor George Lindis Hammond, to talk about the, it seemed to me to be a policy issue. George, did you want about the insourcing and what our objectives are? George, would you like to comment on that?
Thank you, Chair. Yeah, I'll let Joe answer the second two because it's a little more technical. I just want to explain the language around insourcing. Absolutely, it isn't about seeking to create some kind of Sheffield Council care company out of the distress of any care group. As Joe outlined in previous answer, and the report outlines, absolutely 100%. Our first approach, what we're doing, what we will do, is to protect care providers, to work with them to make sure that they can, wherever possible, come through COVID, through the winter, and any other pressures, particularly around the levels of vacancy that they're facing. But what I will say is this. I've been really, really clear with officers who develop policy that when we do have to reach a situation with providers, which happens now and then, and could be something that happens more in the coming months, I want to make sure that as far as possible, as an organisation, we are prepared to have on the table options for how we might step in to protect residents. I want to make sure that we have the options available to the council that the people of the city can rely on. That doesn't mean that that's what we'll do in every scenario, or that's the first choice. It is simply that I'm really, really clear that I want that to be an option to consider to best protect residents, and that's as simple as what it means there. So I hope that helps. I'm sure Joe can answer the other two questions and also comment on that, of course, if she wants to.
Thank you, George. Joe, did you want to add to, answer the other questions from Councillor Sue Alston?
If it's okay, I will. I don't think there's much to add really, except that is absolutely what George has said is absolutely where, what is meant in that report really, is that it would be a consideration rather than seeing a good provider fail and the impact on residents. The other question, I'll answer your second question and then I'll hand to Nicola Shearston for the third question, because that's the area of the report that she has written and which she's probably best placed to respond on the detail to. So I think your point was around too many people, or the point that is in the report about too many people in care homes, and actually, it is the right thing for some people, and it shouldn't be sort of disregarded or sidelined. And I think to be clear, I think where that too many people comment comes from is that when we look at the balance that we have in Sheffield of provision, it's probably, we have historically had very high levels of admissions to care homes, higher than we would want to have and higher than a national benchmark by some measure. And we have, for us, that we have to challenge ourselves as a system that we're not putting people into care homes because that's an easiest option. So where we've been challenging ourselves is in shifting that proportion, if you like, that the way that mix works in the city, so that we have closer to the number of people maintaining independence in their own home or in their own tenancy, rather than the level at which we've had people in care homes. That said, I think, as Sarah has said, in relation to hospital discharges, absolutely, where it is the right place for somebody and where it is the best way for their needs to be met, and it is their wishes or it is in their best interest, then care homes are absolutely play a fundamental role in supporting vulnerable people in the city. And this is not about sidelining that provision. It's about ensuring that provision is a positive choice that meets someone's needs the best possible way, rather than a kind of an automatic reaction of a system under stress.
Okay, thank you. And you, Nicola, you were going to respond to the comments about the consultation process.
Well, thank you. And I think what you raise is really 2 points about it. The first point that you raise about not being able to argue with what's in there, I think is a really valid point. What we've tried to do in this initial consultation, which is about creating the overall framework, is really pull together what already exists in the city. So we know we've already got a lot of good practice, we've got a lot of strategies, we've got some legislation and policies that we already work within. What we've tried to do from that is just almost go out to consultation to check in that we've heard that correctly, we've heard the feedback from people already. What we didn't want to do was ask people the same questions again that they've probably told us we've asked over a number of years, and they've told us the answer and they want us to make the changes. So we've tried as far as possible to say that we've heard that, and we've framed it as to this is what we think we've heard. And this first consultation is as much as anything about getting engagement from a broader cross-section as possible. So we've already had, I think we've had about 50 responses now, and we've got quite a lot of those responses really expressing an interest in engaging then in the more deeper analysis and the deeper needs analysis and modelling that we do across the city, which is probably one of the strongest purposes of this first part of the consultation. I suppose that links to the second question you raised about have we involved organisations as well as the public, and we absolutely have. We think we've gone as far and as broad as we can with those organisations in engaging them and encouraging those organisations to distribute and engage with partners that they may know that we've not even engaged with. So we have gone across all the providers and providers and professionals, and we've had feedback from those as well about wanting to engage further. I think it's just important to point out that as I say, what this is developing is that initial framework to work within. What we'll be then doing is working on a number of areas which we've outlined in the report, which means we'll be doing further work on engagement so that we can co-produce and co-design new models for the city. So I appreciate your point. I think it's been done with almost a deliberate purpose behind it at this stage.
Okay, Sue, did you want to come back on that, or are you satisfied with the response?
Thank you. I would just comment, going back to the first question on point 3 on page 20, that actually saying in writing optimises opportunities for insourcing doesn't sound like a sort of last resort scenario. So maybe the people might want to have a look at that. Thank you.
Okay, thank you. Lucy, you're next, please. Lucy Davis from Healthwatch.
Thank you, Kate. So I've got 2 questions. The first one relates to the immediate picture and the preparedness of the care home sector now, and the second one relates to the paper. So in terms of the immediate preparedness, obviously the questions and the discussions so far have quite rightly focused on the importance of infection control, PPE and so on. Just wanted to ask a question about kind of the other aspects of people's lives. So what discussions are taking place about people's residents' well-being and their human rights in a situation where they're being once again restricted even more in terms of visiting rights and so on? And what will we do? What are we doing to mitigate against that, and to actually monitor the impact that that's having on people in care homes? And the second question relates to the paper. On page 20, it quotes the bit of the Care Act, which is kind of driving, obviously, the need to do the market review and keep tabs on the care home market. If I can just quote that, it says, a high quality, diverse and sustainable care home market is sufficient to provide choice to meet people's needs and promote and support their well-being. But when you look at the commissioning principles, actually, I can't see any of those that are referring to any analysis of people's experiences, how well it's meeting people's needs, and what people's sort of take would be on how well the current market is working for them. So thank you.
Okay, thank you. Who wants to take the lead on responding to those questions? Don't all volunteer. Joe, do you want to say something? I mean, obviously, there's been so much already about the heartbreak and so on. Every day it's on the radio, then the media and so on. And we, as councillors, we've all had casework from people as well. We're completely devastated by not being able to have contact with their loved ones at a very, very difficult time. I just wondered if there's anything new to say about that, really.
So I can update that we are holding a very regular task force at the moment, which is a task group, which I coordinate, but which includes our principal social worker, colleagues from public health, colleagues from the CCG, from Infection Prevention and Control, from Sheffield Teaching Hospitals, from St Luke's, and we are just in the process of setting up a wider reference group, which we would like to invite Health Watch and Age UK and a number of providers really who have different starting points around the question of visiting to join. And we've been looking at exactly this, the challenge of balancing risks in this context. So risks of infection and risks to people of not having visitors, for example, not having certain access to people that they love, the difficulties for some people of using technology to do that, and etc., and PPE for some people, for example, in order to facilitate it. And that becomes more pressing as we face a dark, cold winter as well, with a lot of visiting having been outdoors. So we are working on that, and we have a letter which we are finalising between all partners in the system at the moment. We've had to kind of re-look at it in the context of what tier 2 means for Sheffield. So it was all ready to go last week, and we're just having to just review it and make sure that that's going to land right with providers. But we absolutely are emphasising to care homes the importance of facilitating safe visits where that is essential to the person, or where their circumstances are exceptional and require them to have that context for their health and well-being. It is a very difficult arena. Some of the care homes have lost, I think the highest number of loss was 27 residents in one home. They are very anxious about this, residents, for their reputation, given the levels of vacancies. It's a very competitive market now as well. So it's also difficult from an insurance perspective, and I know that sounds really boring and techie, but it is a significant concern for providers. They're already struggling with insurance, and doing anything which doesn't sound like, exactly what's written by the government is really challenging for providers, especially those with big group homes, for example, where they are facing very different restrictions in different parts of the country. So we are working with the sector on that. I don't know, I know Greg Fell's on this call, so I don't know whether there's anything that Greg wants to add from a public health perspective, or whether I've kind of covered it. I've got to move rooms because my children are booting me out. So give me a moment while I move rooms.
Okay. Sorry, Greg.
So hello, sorry, I've been listening in the background. I'll talk really slowly whilst Joe moves rooms and see where we go. Nothing much to add. This was the hottest of hot issues in my inbox for about 4 or 5 week period. If anyone wants to help balance the risks and benefits of being able or not being able to visit your elderly relatives, I'm more than welcome for other people to join us in the party. It's a genuinely difficult and very, very emotive job. We're trying to strike the right balance. I mean, to overly characterize the position, not being able to visit your elderly relatives carries consequences for you and, more importantly, your elderly relatives. There are well-documented risks of infection in care homes, and balancing those two together in a very emotive and legal environment is, well, it's a nightmare, actually, put bluntly. So we think we've got to about the right position. We are supporting the independent care sector. It is the independent care sector after all, but we are supporting them as best we can. It's worth me saying that the paper published by Sage on earlier this week made clear that the impact of visiting is actually quite small. There are some uncertainties about that paper, and it has to be very, very, very carefully risk managed. And the other thing that's worth me saying is that most of you will have clocked that Sheffield has been put into the medium risk category. It's actually called the high risk category. It's the mid level, and there is something, I'm fairly certain there's something in there where it says visiting in the context of care homes should be in exceptional circumstances. Now, we need to work out what exceptional means, but it's worth us saying that that is the law of the land now. It's not guidance, it's the law of the land. So again, that puts us into a fairly tricky position, and the balance and trying to manage and minimize the risk remains, but there is risk. There's no doubt about the fact there's risk on all sides of the equation here. So one of my team is supporting Joe, Sarah and others in terms of how best to manage that risk as best as possible for the benefit of everybody concerned. I'll shut up there.
Thank you, Greg. Has Jo rejoined us? She did briefly, but so Lucy, we'll come back to your second question once Jo's back in. Oh, I'm sorry, Jo. Are you settled or resettled? Yeah, are you with us? Jo, are you with us? Yes.
Yes, I am.
Okay.
I'm gonna turn my video off though, if that's okay, because I seem to have poor bandwidth all of a sudden.
Okay, so
it was,
this second, you get second question from Lucy.
yes. So apologies if my connection goes a bit wonky. You'll have to just shout at me or wave or something and hope I see. I think, Lucy, you were talking about the Care Act and the commissioning principles not reflecting fully the health and the well-being aspect of what's described in the Care Act, and I think that's a really fair point, and I think that's something that we can look at. It is something which in longer documents in other places we have talked about the well-being principle that is enshrined within the Care Act, and I think probably we need to make sure that that is included in our commissioning principles more clearly. I think the focus does tend to be, have we got enough? Is it quality? Is it diverse enough? And I suppose for me, the quality, the quality of care should involve all aspects of someone's well-being, but it's not explicit in that kind of shorthand. And I think it does no harm at all to make it more explicit in that description. I'm quite happy with that. That's really helpful feedback, Lucy.
Thank you for that. Lucy, are you okay with those responses?
Yeah, could I just ask Jo whether it's possible for you to share with us at Healthwatch the kind of wording that's being sort of sent to providers around visiting, just so that if people are coming to us with questions, we know what the sort of city stance is, if you like, and what people are broadly. I know you can't compel people to work to a certain sort of system or model, but it will be good to know what the general guidance is.
Thank you, Lucy.
Thank you.
Thank you. And apologies to Councillor Angela Argencio. I did miss you. I apologise. Would you like to ask your questions or make comments now, Angela?
Yes. Could we have the wording as well? Because sometimes our constituents may ask us. So if we could have that wording, what we're sending to care homes, that would be really useful for all of us. I have one question that is very specific to do with the report, and then one that is more related to the general COVID situation. So it's on page 29. Could you remind us? It says in total the council has spent £10 million, of which 4.2 million come from the government. So where has the rest of the money come from? Could you just remind us? We've probably been told somewhere else. But it's not clear from this particular report. And thank you very much for the report. It's very useful. And I know that a lot of work has gone on. I'm just wondering, and this links to the next bit of the agenda, what the kind of projection of the issues that we're going to have in winter in particular particularly in December and January, when other ailments hit care homes and there's a very high incidence of deaths around, the cold months. So are we going to use what we've learned about infection control in terms of COVID, and how are care homes being supported? Because I think the way the virus has hit certain homes more than others has highlighted how some homes are very good at infection control and isolating their residents when there is an infection, and others weren't as good, and therefore maybe they were hit more. And also, have we commissioned any kind of studies in terms of looking particularly at the impact of the isolation, not meeting the families, on people with dementia in particular, because it's harder to explain to them why they can't. I spoke to someone that had not seen their mother since I think March, and she has dementia, and they were just wondering what kind of condition they would find her when they finally got to see her. Thank you.
Okay,
Are you still in the hot seat?
I'm happy to remain in said hot seat. Yes, so the first question I think was in relation to the investment into the care sector over the COVID pandemic, and yes, a significant chunk of that has been the infection prevention control grant from government. So that's the figure that you quoted, the 4+ million figure. The rest of the investment has come from Sheffield City Council. What we have to remember is that a proportion of that is what we would have spent on those care home beds in the city anyway. So a chunk of that can be described as in our base budget, because we would have been funding care homes at the kind of rate that we continue to fund them, because they would have had people in. So that is the rest of where the rest of the spend has come from. The winter pressures for homes, the broader winter pressures that you ask about. So yeah, absolutely, we're working with providers on accessing flu vaccination for staff and for residents. We're working with primary care on that as well, and pharmacies. And we are always at this stage of the year talking to them about their winter planning, their business continuity, their staffing, and that was, that's no less the case this year. In terms of, the impact of winter for care homes, it does remain to be seen whether we will see the same degree of transmission of things like flu and cold, given the level of PPE usage and infection control now operating in care homes. It also remains to be seen how many of the deaths we've already seen were, if you like, accelerated deaths, and whether the expected number of deaths we might anticipate over winter does manifest, or whether we actually see, more unexpected deaths, COVID related, or whether we see lower deaths. This is all really quite difficult for us to anticipate. So I think really we have to just continue to work very closely with care homes and the other providers, types of provision in the city, to identify when issues, where risks that we've all identified collectively start to become issues, and to act quickly to support providers and support residents. The final one around studies around the impact on dementia, we haven't commissioned anything directly as such, but there is an ever increasing amount of research out there, not all of it yet peer reviewed, it has to be said, but we are working with colleagues in public health and across the CCG and teaching hospitals, and regionally and nationally, to understand, what research there is what's robust and what we can learn from that. And I've asked one of my team who has had quite a lot of training in dementia to join the task force that I mentioned, the task group that I mentioned earlier about balancing risks, to help us have that specific insight around dementia into that group. So we are aware that, you know, there is impact, and we know that from our first-hand, you know, from the letters we receive, and I know some of you will have received, which are very, very sad. And we know that there is some international research in this space, and we will, you know, do our best to keep abreast of new research as that is published and peer reviewed, and to inform our practice from that.
Thank you, Joe. Greg, you wanted to come in here?
Thanks. Only very briefly. So Joe, I'm very pleased that Joe's in the hot seat. Makes a change for me not being in the hot seat.
Yeah.
So
a break there actually.
Yeah,
It was just she dubbed you in.
Joe can be in the hot seat for as long as she wants. But enjoy the learning in terms of kind of managing risk. I think the sector and us and the CCG and the teaching hospitals and others have ongoing and iterative learning. I think we've collectively learned a huge amount. There's actually there's a lot of system and process in this place now. When people ask me what I'm worried about, everyone says you should be worried about care. I'm not actually worried about care homes. I am worried about care homes, but there is system, there's process, there's structure. We've got a mechanism to manage that. The response of the sector has been amazing and genuinely astounding. It is no doubt it's been difficult, no doubt it will be difficult, but the response of the sector has been pretty good actually. It's probably not fair, in my opinion, to say that some homes have been better than others. It's an impossible thing to measure. It's an impossible thing to call. I think the response of the sector has been pretty good, and the sector and others have put in a big effort. Some homes have been less lucky than others. There's no doubt about that. But most are in a pretty good place. There are one or two that we may worry about a bit more. We provide more support to them. The flu, cold, winter death point, flu kills people. I made the mistake of not getting my act together to have a flu jab a few years ago. That was the year I got flu. I was reminded quite how nasty an illness it was. It laid me out for days. But looking at what's happening in the message, get your flu jab, looking at what's happening in the Southern Hemisphere, flu admissions have dropped off a cliff. Flu admissions have dropped off a cliff in the Southern Hemisphere. It might be because the Southern Hemisphere went to town on the flu vaccination campaign. That's probably true. It might be because it was a mildish flu strain this year, and I don't know that. It's almost certainly in the mix is that everybody's washing their hands a lot, wearing face coverings, keeping their distance a lot. So the things that protect us from COVID are also things that protect us from flu. So my sense is there will be less flu deaths this year. Find some wood to touch because I wouldn't want to make predictions, but certainly Southern Hemisphere gives some cause for hope there. Lastly, on studies, no, we've not commissioned any studies in particular, but there's lots and lots and lots of lived experience out there. We all know, you all know that as well as me. You only have to turn on the news about 3 or 4 times a week and you see the lived experience. I'm not convinced what commissioning lots of studies would help add to the lived experience. Actually, the lived experience is blindingly obvious. Quantifying the impact might not help us change the fundamentals. We've got to sort the fundamentals. Is my view. So that's all I'd add to what Joe said, and now I'll put Joe back in the hot seat.
Thanks, Greg.
Thank you. Angela, did you want to come back on that?
Yeah, just to follow up. Sorry, just to follow up on the money, can you then confirm that 5.8 million would have been what we would have spent more or less on care homes in this period? Because it seems like I'm just interested to see. I'm not saying that we shouldn't spend it. I just want to know where it's coming from exactly, which part of the budget. And I think it should be made clear in the reports. Where the money is coming from. I mean, it's money well spent, I'm not contesting it. It's just I am surprised that the government funded just less than half of it. So I was just wondering where exactly the money was coming from.
John, did you want to comment on that? You've usually got your finger on the pulse of our finances.
Well, I think we recall that the total bill for the City Council of the COVID impact is about twice what the additional funding the government have provided to the local authority. So funding has come from the local authority with support from the government, but currently the amount of money that the government have provided is about half the amount of spending. So it's not just what we would have spent in care homes, it's also an additional ask of us at this time. I mean, it is money that's going into the care sector for the care sector to support some of the most vulnerable people. So sometimes we look at it as supporting organisations, but it's actually supporting the people they support, isn't it? That's what we're trying to do. So it is a significant ask on the City Council, and you might be aware that councils up and down the country have identified this pressure and this problem for them, and it is contributing, as Kate mentioned, to the financial pressure in the council. But when you're faced with the kind of challenges we have been in the last few months, it's something that is a must do. But we have worked closely with the market on how they are adjusting to their vacancy levels and this new situation in terms of the financial challenge on them. So it is something we do very carefully, and our strategy right from the beginning was to understand that it's very different in very different homes. So it's not just about blanket funding, it's about understanding each home's individual circumstances. And that itself has been quite a challenge. There's over 100 homes and about 50 home providers. So we're getting a closer relationship with the market as we can, so we understand their specific position, and then we provide the funding that's going to make the difference in that setting as much as we can.
Does that clarify for you then, Angela? I just think the way it was written in the report.
Not really, but I'll ask the question again in another setting.
I don't understand what it is that you're seeking, which people haven't responded to. So what is it? I mean, basically,
I was just wanting to know where it's come from, which part of the budget has come from, but it doesn't matter. I'll ask again in a different setting. It's okay.
George, you wanted to come in on that.
I can thank you. I can try and help, Angela. I just think, just to be really, really clear, Joe set out that actually, some of the additional cost absolutely is because is tied up with the complexities of the vacancy rate. But when we really, really clear, this council is spending money to keep people safe in COVID-19 that is not budgeted for, that we have to deal with as a city. It's because this government said that they would support the councils with all the costs related to coronavirus, and they lied unless they come up with the money tomorrow. And that's the problem we've got here. So we will have to respond to that. We will be responding as a council financially to this, but it's not money that we found in a part of our budget. It is additional spending that we had to do, but we are not being, as of currently, refunded by the government for in full. The government need to do that, and that's absolutely crucial. And we've called time and time again for them to do that, and we continue to do that. But there's no part of the budget for 100% of this money. We will do everything we can to minimise the impact on the wider budget, but we can't do that because we have to make sure that vulnerable people are protected. We're doing that, and the government need to help us with it. Okay,
thank you. I'm just very conscious of time now. I've got one last person to come in, and I've got some comments that I want to make as well on the paper. So, Adam, can you make it reasonably brief, please?
I will make it as brief as I possibly can. I did just want to sort of ask a couple of questions, because I take the really on what Greg was saying. I certainly accept that some care, this idea that some care homes are doing better than others. But what I did want to do was just ask a couple of questions, and they might not be particularly fair. But what are we doing in terms of working with the CQC and as commissioners across the board? Our own quality assurance of services. I know my last proper job was doing quality assurance in care homes, and they do vary incredibly. And there's some places where I've booked myself in next week, and there's some places that I want to send my, and we do have quite a responsibility on that. And then the other one, and I might sound almost sort of Tory-ish and hard-hearted. It isn't meant to be. But I think that there is a real issue, like you said, Greg, about how infectious this disease is. But I think different people in care homes will have different levels of capacity and different levels of being able to assess a risk about seeing a loved one and what that does. And there's no good answer to dealing with this pandemic, but I do want to make sure that people's individual choices are, as far as is practical, respected, obviously provided that they're not doing harm to other people. And I just wondered if anybody had any comments to make on those. Thanks, Chair.
Thank you, Adam. So 2 things. Well, I think the answer to your first question is going to be fairly straightforward. The work with CQC on quality and so on. There's some stuff about it actually in the paper, but Jo, did you want to say any more about that?
Yeah, just to say that we do work really closely with CQC. We involve them in all of our risk highlighting and risk escalation and market reporting work. So they are cited on that. And we have been working closely with them to instigate, well, we've been doing this for a couple of months now, our virtual home care reviews, and we are working with CQC as well now on how we will do, taking into account the restrictions of being in tier 2, how we may assess quality again by being in the setting or by other means. It is a concern for us in terms of having eyes on and footfall through care homes, that we're not that there isn't the footfall that there normally would be, and there aren't the number of professionals or family members in a care home, and we're working really closely with CQC on how we can address that, and we work really closely with CCG as well. So we have an integrated quality and risk framework, and we work together with their clinical expertise and our kind of contract management and quality assessment work. But I would say that this presents us with some real challenges, but also some real opportunities to think about how we understand quality in new ways, really, and how we find ways to assess that. The question about capacity. I don't know whether Sarah might want to come in as a bit more of an expert on all things capacity related, but I absolutely take your point that we need to understand, people need to understand the risks that they're taking, or somebody needs to support them in terms of what is their best interests. Sarah.
Sorry, I was just going to quickly jump in, if that's all right, Chair, because I am reassured, because I don't think it's just about the CQC. I think it is about the CCG, because my view is we should be ensuring the quality's there before the CQC even gets in. So I was reassured by that.
I'm also, I know there's joint work and so on, and visits and all sorts of stuff, but okay. Greg, did you want to come in on this?
Just very, very briefly. So I have a feeling I pay for it. I think I do. The infection prevention and control nursing team that's employed by the CCG, they're commissioned by me. They've been hugely active in this space for many years. Sort of some time ago, I think it was Jo marched me into a room of care providers to basically read the Riot Act on infection prevention and control as a critical part of quality. Made me very unpopular that afternoon, but it did spark a whole heap of exceptionally useful work where we've embedded IPC into the core quality standards that we expect from the sector. And to be fair, the sector have responded pretty well. That was pre-pandemic. During the pandemic, the IPC nurses have probably been busier than they ever have been, and probably busier than they ever will be in the future. And they're very active in NHS settings, of course, but they're also very active in care settings, actively providing support. As well as wandering around with clipboards and marking people's work. I'm kind of assured that's pretty good actually in the care home sector. There's a bit of work to do in other bits of social care, but care home sector I'm pretty happy with. Whilst I've got the floor on the ability of people to understand risk and benefit, I agree 100%. One of the things I'm mooted, but I think it's just operationally not workable, is that the residents of a home are collectively consented to what level of risk and tolerance risk tolerance they've got prepared to accept. It's just probably not workable operationally for all sorts of reasons. But yeah, I agree with you. We're sort of individuals take risk and accept benefit, but in the context of this, everybody bears the consequences of it going wrong, and we just need to be continually vigilant on that one if we can't get a collective consent process, which I do think is just impossible. It's a nice idea, but it won't work.
Can I just add to that very briefly?
I was going to ask you, Sarah. I know you've got some work to do in the next paper, so I was sort of giving you a bit of a rest. Carry on, please.
Yeah. So just to remind everybody that there is an existing legal framework and practice framework around the balancing of risks and choices. So the Human Rights Act, the Mental Capacity Act, and the Deprivation of Liberty safeguards have not, as far as I'm aware, been repealed by any more recent COVID legislation. And I think one of the core jobs of social work always has been basically balancing the tensions between competing bits of legislation and identifying and managing and balancing risk and choices and benefits. So just in that context, actually this challenge is nothing new, but obviously there's some new and interesting twists to it in relation to the government sending out or setting out new policy, new requirements that are almost directly at odds sometimes with existing statute. However, all providers are well aware, and again, it's a regulatory requirement that they're well aware of how they should operate within that pre-existing framework around capacity and choices. So if they are restricting somebody's liberty and the person isn't able to consent to that, then they should be identifying a way to assess the person's capacity and work through a best interest conversation. And what Joe described earlier, the work of the task group that I asked Joe to lead was about providing support to all care home providers just to help them to do that, because it isn't practicable or manageable for every care home to send in a DOLS authorisation request for every single resident, because we would be overwhelmed. We're already overwhelmed with them, quite frankly. We wouldn't be able to go out and carry out a best interest decision for every single person. But yes, they absolutely should be talking to individual residents and talking through risks. And also, just to say, worked in care homes for 10 years at the start of my career in social care. Again, the job of a care home registered manager mainly is about trying to balance risks to the community against impact on individuals or vice versa, and it's never ever an easy thing to do, and honest and open conversation and trying to kind of work through compromise and negotiation is almost always the best way. The added wrinkles again here are things like insurance providers refusing to provide indemnity insurance if care homes let people in when they're positive, or let visitors in, and so on. But just linked back to the quality assurance, so we're quite clear that where the government says, or said this week, that if you're in tier 2, people should only visit care homes in exceptional circumstances. For us, the nuance is working out what's exceptional. Now, all of the work that my staff, if we feel we have to go into a care home, we think that's an exceptional circumstance, because we'd only be doing that if we thought it was absolutely necessary to assure the safety of an individual or the safe practice of that home. But we'd absolutely make sure that we were, putting in place as many risk mitigation measures as we could, and we'd be very cautious about, not becoming ourselves a risk to individuals. So yeah, the whole conversation is not an easy one, and we need to continue working through it. And my heart goes out to people who haven't seen their relatives for a long time. And we'll, part of the letter that Joe's sending out is that we are expecting providers to make sure that residents have contact with family and friends, contact through a number of different means, but particularly there are certain points in time when we'd say that contact, that visit is exceptional, an exceptional circumstance, and should be supported.
Thank you. We're coming to the end of this session. I've let it go on a bit because we've actually brought in the whole issue spontaneously about readiness and preparedness and stuff as well. And thank you very much for that. Just a few quick comments from me. They're not for discussion particularly. Having looked at the principles on page 25, I just felt that there was nothing in there about carers. And that's obviously a major issue in lots of, with families. It's not just about the individual, they are part of a family, and I would hope that that could be part of the principles that we adopt. I'd like to see something a bit more about diversity. Again, it's not reflected in I think it should be part of the consultation. It should be part of the looking to the future, that we ensure that we've got a diverse, that we've got arrangements in place to meet the needs of a diverse community. I think that's, I mean, I'm sure you with that's implicit, but I think we need to make it a bit more explicit. There's nothing in there about potentially looking for new models of care that work better for people, and or organising providers in different sorts of ways. It's very much based, at the moment, it looks like it's based on the existing model. And the final thing is about affordability. For me, that's the elephant in the room. And you know, this government has just lost all credibility for actually promising big and delivering, not being able to deliver. And that's we don't want to lose people's confidence and so on. So we don't start off with money, but we do need to recognise and be realistic. I think that we don't want to raise expectations to such an extent that we will have to, council's going to have to be able to afford whatever it is that, whatever model that we have in the future. So I just feel that it's something that we shouldn't start with, but we ought to be cognizant of. So those were a few comments from me. I'm not really asking for discussion about them. Adopt them if you think they're useful and so on, but we've not really got time to discuss them in any detail this afternoon. So can I thank you very much for the papers. The papers were very good. I know there's a lot of work went into them, and there's going to be a lot of work over the coming months, at the same time as continuing to support our residential care and all our social care providers during another exceptionally difficult period. Just to sort of, what I usually do at this point, I'd like to thank you for everybody for the contributions and the answers to the questions. At this point, I usually try and summarise some of the issues that I think have been raised during the meeting for the purposes of the minutes and so on. So this has really been a session of two parts really. One has been around the state of preparedness for this second wave. And I think following responses to all your very challenging questions, my sense of what the response we've had is that overall we feel and we hope that we are better placed at this point in time than we were in March and April last year. Better systems and processes in place to protect vulnerable people in our, particularly in residential care. I say hope actually, because we can't actually guarantee against it. So you've given us some, some confidence that we are better placed. We also talked about the future direction, because that was really the main point of the discussion today, although we've had to adapt that. And we had some comments on consultation, I think that you might want to bear in mind, and on commissioning principles. I think there was a recognition that well-being should be more explicit within those commissioning principles. And I've made some comments as well about carers and reconciling their needs as well. And we were really pleased to hear about some of the attempts and efforts that are being put in place to try and deal with the really heartrending situation about people visiting relatives, loved ones in residential care, although we do recognise how the risks need to be balanced for everybody. But we're pleased to hear about the task group, and hopefully Lucy can join in with that. And also the letter that's going out to homes as well to ensure contact, whether even if that can't actually be physical contact as well. So I think that's my sort of summary of what I've heard this afternoon. Have I missed anything significant out that people would like to add to that summary? No? Okay. Can I thank everybody in the hot seats and also those of you who've been asking very challenging questions and at a very difficult time. So thank you very much to everybody. And then we're going to, shortly we'll move on to the next session on continuing care and winter planning. We're actually in that point at the moment, aren't we? But thank you for those of you who are going to go back to your children, etc. Thank you. Bye-bye.
Thank you.
Kate, could you bring in, well, I know Sarah's already here, and it's Alan. Oh, you're bringing in Alan, that's fine. Oh, and Danny.
Coming in, Chair.
Thank you. Is Danny going to appear? Oh, yes, hello. Okay, welcome to Alan and to Danny. First of all, apologies for overrunning. As you can imagine, you know, we've also really, you might have heard some of it, I don't know if you'd heard it or not, but obviously with the second wave coming on us so quickly, we have spent some time actually looking discussing the preparedness, particularly for the residential care sector at this point in time. So would you like to introduce yourself? Alan, would you like to go first, please?
Yes, thank you, Chair. My name's Alan Windle. I'm the Chief Nurse at Sheffield CCG.
I am Danny Hydes. I'm the Head of Continuing Healthcare for Adults and Children.
Okay, and would you like to briefly introduce the paper? Who's going to do that? Or did you want to just say a few words? Sarah, did you want to say anything at this point?
Yeah, I was going to introduce the paper in terms of winter planning. I wasn't going to say much really, other than hopefully people have read the paper and recognise there's an immense amount of work going across all health and care providers and organisations in the city to do whatever we can to be as ready as we can for the foreseeable and the unforeseeable. And in terms of the unforeseeable, that's mainly about having the right set of priorities, principles, networks and relationships in place so that we can work together as a set of organisations, you know, to understand what we're seeking to do to support each other and work towards the best interests of people in Sheffield, acknowledging that it's likely to be a tricky winter, if I say that carefully. So I wonder if we want to just do winter planning and then ask Alan to introduce the section on CHC as sort of two separate pieces. Kate, it's entirely up to you.
Well, that's absolutely fine. It may well be that the questions sort of cut across. Can I just ask? I mean, there was obviously in the paper there was reference to the guidance from government in terms of the arrangements. Has that been changed at this point in time? To see what I mean, that we heard previously that a lot of the, particularly the continuing healthcare arrangements and so on, which were, they worked differently during the earlier stages of the pandemic, and then we've returned to the status quo in September. I just wonder whether the situation now that we're in, you know, there's been a second wave, whether the expectation is that what the circumstances will be in relation to how continuing healthcare can work. The two seem to me to be a bit tied up together, really.
Would it be helpful, Sarah, if I just give the quick overview of the section of CHC and then members of the committee then can raise questions, so I can pick up Chair's view there. Do you think that would be helpful?
Yes, because then we can ask questions. People may want to ask questions about them both.
So from a continuing healthcare perspective, if it wasn't complex before, it is now. So as we led up to March, Chair, you were aware, myself and you and Sarah actually met for scrutiny that was planned for earlier on in the year, looking at how we were collaborating and working together more closely, working with partners like Health Watch in order to look at the feedback that continuing healthcare has received and do some measured actions in order to improve the customer type service that we were delivering. And I'm pleased to say that that has continued throughout the COVID period, and we've now got a strategic group set up that both I and Sarah attend, that continues to look at aspects of continuing healthcare, even though there's significant changes in place, to ensure that we're meeting that expectation of Sheffield's population. So from the aspect of COVID, members will be aware that continuing healthcare ceased within relation to, it didn't cease in totality. What ceased was the assessment, the DST element of continuing healthcare. And at the time, the considerations were being made on what do we do with the staff for the continuing healthcare staff. So Danny, who's on the call, who might help me out if I get lost a bit later on, absolutely worked with the local authority. Myself and Sarah looked at as a system-wide discharge hub, and we moved into a discharge hub that looked at discharges from across the city for STH. And while we weren't assessing individuals, we were making a determination of whether we felt that somebody would be kind of requiring care. The care from March up until September was classed, as you'll see in the paper, we call it COVID funding. So what government put in place is a process by anybody who was being discharged, and we were doing rapid discharges, attempting them in 24 hours to free up those NHS beds for the anticipated COVID patients, was that we were applying the care that individuals needed, a decision was made, and the funding was made centrally. Throughout that period of time, again, from a health perspective, from an NHS perspective, we were feeding back through the national system. Actually, this is working. Apart from COVID, this is really good. That, you know, the benefits to individuals rapidly assessed and moved into care provision, and then being funded, you know, was a benefit to the patients at that point. As COVID and Greg's view, when I hear a lot of public health consultants as in, well, this second wave that we're coming to now, as we were going from the first wave, some describe it as all one wave, we're just fluctuating in wave one, is that we were instructed by the Department of Health and Social Care, government, that to reinstate DSTs from the 1st of September. So therefore, from the 1st of September, we have kind of got 3 cohorts of continuing healthcare patients, and that's kind of described in the paper. So we've got the historical cases that were pre-March, that we continued through the COVID period to continue to care manage. So we were still checking on those individuals to ensure that their care needs were met. There was the second group who'd been funded. So actually everybody who was discharged and requiring care and support were receiving free care there, irrespective, you know, from a health perspective, irrespective of what the outcome of the assessment were. And then we were reinstigated with the third group from 1st of September. Overarching the changes from the 1st of September, when we reinstated DSTs and provision, there was additional bit of learning which I believe was a reflection of the COVID period, is that we can centrally again pull resources. It's kind of a mini COVID fund for a 6-week period. So people requiring support post-discharge from hospital would get a 6-week assessment or review process to see what their needs were post-discharge from hospital, is how I like to describe it. So, and that's where we currently are at the moment. The complexity of us working together is that we're pulled in 3 different directions. The 3 different directions are historically funded, pre-March, that still need to continue to be reviewed and assessed. There's the COVID period, which there's some debate around how long these group, between the March and September group, how long they will receive free funding for until we complete an assessment. And so that is still, you know, current guidance is that they'll be funded until they receive assessment, but the CCG is working under stringent focus from NHS England improvement to complete those as soon as possible. And then there's the third group, which we've had to apply resource to, different types of resource to the other two groups, because they are requiring assessments, both health and social care, within that 6-week period of being discharged, or the package of care then comes back to the relevant organisation to fund fully until the assessment's completed. The challenge for the public sector in this, and I have had a discussion with the majority of MPs in Sheffield, is that there's a disparity in funding on those three groups, because we've got the March to September group that would be receiving continued funding until assessed, whereas somebody being post-discharge in September would have 6 weeks and then be funded by a relevant organisation. So there is a slight disparity where we are, again, we are working again with Lucy in Health Watch and the CCG and with the MPs, and please a call to councillors as well here, is that we would anticipate at some point potentially some challenges coming ahead, either increased in complaints around the disparities in those funding streams somewhat. I think that just about covers, so sorry, your question, Chair, going back to your question with regards to what is the anticipated changes as we're now going back into this level 2 potential. Everybody's got a potential of going into that level 3. We've just heard Greg, is that services this time will be ring-fenced, so we do not anticipate that the service within relation to CHC will suspend like it did in March by any means. I think we've learnt from that as well. Department of Health and Social Care and NHS England improvement are determined to continue to press on.
Okay, thank you for that. Now I'm opening it up to questions about winter planning and continuing care. Who's going first? Councillor Steve Ayres. Steve? And then Jane.
Yeah, mine was just a quick question, really. I'm just thinking in terms of the groups and the work streams that you've highlighted. Just wondered where treatment of patients suffering the effects of what is being described in the social media as long COVID or physical or mental health fit within those groups or those work streams.
Yes, so there is some significant continued health needs of individuals from COVID, and so there is a large group. Majority, while living with continued health needs post-COVID, can be and will be picked up through universal services. There is some that will require that continued additional health funding. At the moment, that is being described as rehabilitation. So colleagues familiar with the framework with regards to requiring rehabilitation, and so that could be lung rehabilitation, not physical, but actually it affects physical because the breathing's affected, or long-term organ failure, multiple organ failure due to COVID is another issue, and then picking up the elements of the psychological and mental health effects. So what the CCG has done, again, working with the local authority and multi-partners, is picking up additional resource and focusing some additional mental health and psychological support and wraparound services for individuals that have got this significant effect. And again, not to intercede and go back to your last comments around care homes, significant mental health resources, psychological support has been provided to workforce as well. So workforce who are dealing with the outcome of the COVID pandemic and continued is also being applied there as well.
Thank you. Councillor Jane Dunn, please.
Thank you, and thank you for your really thorough report, Alan. Really, I feel really kind of relieved in many ways at all the angles. I mean, the one question I want to ask is, obviously, discharge. Most people want to be discharged into their own home. Then we could get like another stage of a lockdown. You know, so a lot of people will be responding on people that were maybe in their bubble that would help them. You know, so it's kind of, my question would be is, what do we do if those people can no longer help? What do we do if they come into contact and are contact traced? So we know that people are much better at home and they get well better at home. And I want to say that my mum was discharged earlier today, absolutely brilliant at the NHS. Thank you so much. She's lucky she's got people at home to help her. But what are we doing to help that? And also, we did have mental health to scrutiny a couple of boards ago, but actually I know from the people that I'm talking to that the pressures that everybody is feeling right now, and if you are ill or got a long-term illness that flares, how isolating that can feel. So actually, are we linking those together so people can have someone to talk to, or just because of the general pressure that's coming? And when you're ill, you do tend to feel very isolated anyway.
So yes, thank you. I think it's multifactorial because so to answer your question, what we have continued to do, councillor, is that we have the discharge hub that's continued post the COVID. So the kind of hub that was in place through that COVID period that we resourced continues. However, it is difficult to resource it with the workforce that we now have to stretch across those across that span of work that both health and social care have to undertake. So it still does come back to those. There is a different legislation within relation to discharge legislation that has been put in place alongside the CHC type of new process. So from a discharge perspective, again, resource has been put in there in order to assess the individual's needs. The focus, I think, again, I heard Joe on the last paper, which both Sarah and I absolutely agree with, is that, you know, home is best. People for recovery is almost best. So our focus, whether we're in a pandemic or not, is that we resource what we can to the best we can in order for that individual to go home and live as an independent as possible. So within relation to your question regarding to carers, with regards to family support, it is extremely difficult because, as you know, now we're not allowed to mix households. The response, you know, the response during the COVID period is that family members moved in to support, so they kind of created that bubble. For me, it's making sure that we get that assessment right at the beginning of that discharge. And again, from the discharge perspective that's currently happening in the hub, we have to take into consideration the complexity of the different tiers and the different regulations in order to become best for the individual. I mean, I may be going off piece here. We have to be pragmatic that actually if an individual is at home and they are supported by a carer significantly from another household, you would assume that that's still a bubble and being able to continue to support that individual from both a mental health and a psychological perspective, because that is definitely different to being in a nurse and care home. You know, Isolation can still be isolated. You can be in a full room of people and still be isolated, can't you? And feel lonely. But actually, if there is nobody there at all, equally. So from the perspective of being home, and home is best in order to recovery, both health and social care are supporting that that measure in the best way we can within the relation to the restrictions that we have to work under.
Sarah, did you want to come in on that?
Yeah, just to add really that we do our level best to understand what support people have got available before they're discharged and have good conversations. And generally our staff working in the hospital will talk to family members and try and sort of triangulate their understanding of what support's going to be available for people, so that we don't, wherever possible, we don't send people home without being really sure that they've got the right support. In terms of some extra stuff we've stepped up in the last 6 or 7 months to assist people with that, we do have a sort of an emergency response that we're able to provide to people now. So for example, if a person's carer who's their partner becomes ill and has to go to hospital, we've got some support that we can put in quite quickly, so that we can avoid the cared for person having to go into a care home, for example, or, as is sometimes the case, get ferried off to hospital with them. And equally on discharge, we've put in place wraparound support for people. We've got our Home First team that we've talked about at Scrutiny previously, who is supporting individuals with very practical help. So sometimes it's not about direct care, sometimes it's just sorting out access to money, getting shopping in, making sure people have got the right prescriptions. So we also will signpost on to other organisations in the city, and there's a lot that our staff will just go out and do themselves. So whether it's 11 o'clock on a Friday night or 2 p.m. on a Tuesday afternoon, we do our best to provide that support to people. And I think also we've identified a number of people who have needed slightly more sustained support. So again, what we've tended to do is provide that directly from our in-house council services, and that's from the pool of staff that we've recruited through the COVID pandemic. In terms of sort of extra casual workers, we've actually we've offered contracts to all of those casual workers so that we can, if you like, guarantee the amount of capacity that we've got available to support people out of hours and in an emergency. And we've actually, we've had some really great examples where we've put in a lot of support to individuals just for a short period of time and prevented them from having to either stay in hospital or go into a care home when they didn't want to, and when they otherwise might have done. So actually, I think that, some of the ways of working that we've developed in the last 6 or 7 months in these really extraordinary circumstances have actually resulted in a really creative response, a really good outcome for people. Although just accepting the fact that it is really pressured now, and it will get even more pressured. So we do have to continue to think creatively and try and work together across teams and systems to make sure we can support people. And then just finally, there was a bit of a view that we might be less able to pick up on people who might be at risk in the community or might be struggling. Because we don't have as many eyes on, if you like, we don't have as many people going out and about. And actually, what we've found through our first contact prevention teams is because people are tending to reach out a bit more, and the kind of good neighbour effect is happening, where people are spotting that their people on their street or their neighbours might be struggling. We've found that we've gone into houses and we've been supporting people. Whereas previously we probably wouldn't have got involved, we wouldn't have reached out, we wouldn't have helped them. So actually we've been working with housing colleagues as well as community health colleagues and CHC teams and other providers to just make sure that we're picking up on all of the support needs that people have. Really important for me that we make sure we have not just adequate support to carers, informal carers, that we have robust supportive support to carers. So we don't want to put in just enough so that they're just the right side of breaking point. We want to make sure we put in enough support to keep a carer feeling supported, able to work if they want to do so, able to look after children and other family members and have a life as well. So what we've also been doing is talking to carers really regularly to kind of find out what they need and doing our best to provide that support to people as well. And that, you know, that has an impact in terms of reducing crisis and hospital admission, as well as helping people to come out of the other end of the hospital.
Thank you. Thank you. That was just the kind of reassurance that I think we need to get out there, because I know it's one of the things that I've been asked by my constituents, you know, so that will be really reassuring for them to hear. Thank you. Sorry, Chair, I should have gone through you.
Sorry, Chair. I think there's just one more key point, and it's a very small point, and it's very small numbers at the moment. So the verbal feedback that we've got so far within relation to health and social care on the continuing care assessment, the verbal feedback has been really quite good. Prior to COVID, Chair, we discussed again that we were utilising a questionnaire post-assessment in order to get that feedback. Again, very small numbers, but have responded, but no negative feedback has been received so far. So I'm touching wood as I'm sat here, because obviously we need to continue to be mindful that, you know, we need to as Sarah said, continue to be innovative on how we support individuals, and to continue to do our best in order to get people's feedback, to continue to assess how we are delivering.
Okay, thank you. Can I just ask Sarah, what's the difference now in practice? And I'm almost asking a rhetorical question about our planning for winter and our planning for COVID in winter, if you see what I mean. What is the difference? Are the arrangements the same? And
well, I mean, if I'd have sort of delivered a longer introduction, I might have sort of talked a little bit about how we do winter planning every year, and we brought winter planning to this committee last year, didn't we, about this time. So winter planning really is a couple of things. It's about acknowledging that usually through the winter there are additional demands on health and social care related to the fact that more people get ill in the winter. So people get flu, we get noroviruses, people tend to suffer more from respiratory illnesses and so on. So generally, seasonally, with there's more pressures. So there's something about how we plan for that extra demands through the winter period. The second thing is about what I describe as business continuity. So how do we as systems maintain business continuity in light of things like bad weather and closures due to norovirus and you know, some of the unexpected stuff that kind of happens. So you know, business continuity is a thing that we also plan for and manage year round. And then I think I said something earlier about working through how as a system, what principles we've got in place to manage the unexpected. So if something pops up that we didn't foresee or plan for, what systems and structures can we step up to try and work around that? So COVID is something that's driven extra demand for the health and social care service, in terms of there are potentially more people going to be going into hospital and needing support on the other end of that. And there is potential additional demands in terms of people who previously would have sought help earlier in the year and haven't. That's quite tricky to kind of forecast in terms of how many of those people there might be and what their needs might be. But certainly we know that a lot of people haven't accessed elective care over the lockdown period that they would have done previously. So that's created big backlogs for the health service across pretty much every service. We know that we've lost it. We didn't have the ability to intervene proactively and preventively with as many people earlier in the year, so that might result in the complexity of needs being greater, the level of needs being greater as well. So, but essentially, winter planning and COVID planning, yes, it's about trying to understand what the extra pressure is going to be and plan for that. The slight wrinkle is we've also had a change to the way we operate many of our frontline operational services. So things are slower because people need to change PPE, wear PPE differently, because we can't have a waiting room full of people like we might have done previously. So, you know, you might not have a discharge lounge with a group of people sat in it, and you know, a doctor's surgery wouldn't necessarily have a group of people sat outside. So it slows things down, but also there's a negative effect on the capacity side of our balance sheet. So staff, that's the workforce that are delivering these essential services, some of them are also getting ill from COVID and or having to self-isolate because they're becoming a contact. So that's increasing the numbers of staff that we've got off work at any one time. And again, that's something that's quite difficult to forecast and plan for. Did that answer your question, Kate?
Yes, I think the point behind my question, Sarah, was that we were going to still have people sleeping on ice and stuff like that, and things that happen in winter. And I suppose it's just trying to reassure people that even if they've not got COVID, we've still got plans and arrangements in place to make sure that their needs are going to be responded to as well. That's why I was really asking the question, and I think that's one of the things the committee would, you know, would like to hear, to get reassurance on as well.
Yeah, but essentially, so people need health and social care because of a medical or social need, and there'll be potentially more of them needing it. That's the long and short of it.
Okay. Any more questions or comments to Alan or Sarah or Danny? Thank you for coming, Danny. Nice to meet you, even if it's virtually. Any more questions or comments? Can I ask about funding? Did we get any additional funding this year for winter pressures?
No, is the short answer. No, I mean, the Department of Health and Social Care published the Adult Social Care Winter Plan, which outlined its expectations of adult social care services, along with the support it was offering. The financial support was an extension of the existing financial support. So it was an extension of the IPC fund, actually slightly less than what we'd had earlier in the year, and PPE, free PPE to providers. But no, we didn't get any extra money to deal with the extra demands and pressures, neither did the NHS. So there's a long list of expectations for NHS services as well around the kind of proportion of elective work that they should do. There's been no extra money attached to any of that, unfortunately. Our ADAS, Association of Directors of Adult Services, President did ask the Minister for Health and Social Care in a session that was held a few weeks ago, could the Minister advise what additional financial support would be available to local authorities for adult social care to meet these increasing winter pressures, and there wasn't an answer during that session. The Minister suggested that was a conversation for outside of the room, and we haven't had anything since, I'm afraid. So no, currently the expectation is we just manage within our within our budgets, I'm afraid.
Yes, our already overspent budgets. Any other comments or questions? Lucy, I know we've had lots of issues from people about continuing healthcare, and we've had numbers of questions, people coming asking questions here when we've discussed it in the past at Scrutiny. I was just wondering whether or not people understood the complexity now of all the funding arrangements. They seem even more complicated than previously.
Are you asking me for what we've heard from people in terms of their understanding, Kate? You're on mute.
Sorry, I wondered whether Healthwatch, I've muted myself to allow you to answer. I just wondered whether Healthwatch was getting any feedback on continuing healthcare funding and so on, and the arrangements associated with it.
We had a few queries come through earlier on in the kind of time period between March and September. We anticipated, as I think Alan referred to, or we anticipated that there might be a kind of spike in questions or concerns when the process restarted in September. As yet, I think I've only heard one story that we've had so far, which related to the third group. But nothing, no dramatic kind of negative feedback. I think it's probably still early days, and I think I put in the chat, I was, thanks to Alan for answering the question that I was going to ask about what the feedback had been so far, because I know the paper mentions restarting the questionnaire, which is one way to sort of sense check the experience that people are having. But I think it's early days, and people obviously haven't, I'm assuming that most people won't have had a decision on some of those assessments, many of those assessments that have taken place as yet. Danny. That's my assumptions. So I don't know if there's.
So we've done. I think we've done about 50 so far. Some have still waiting to be ratified. I think we've had maybe 30 that's been outcomed.
Okay.
We're really clear in the communication letters that we sent to families and individuals. And then any further queries or questions that we've got outside of the care management responsibilities, because the nurses are still having regular contact with those who either need an assessment as a result of the COVID backlog or through the discharge hub. That care management links, or sometimes we're speaking to families weekly. If not, we've said that escalations can come to myself or to Alison Hall as Senior Operational Manager. We've had a couple, but they were resolvable, so that's good and positive.
Okay, thank you.
I'm doing the right thing and muting myself, but then I forget to unmute myself. Any more questions or comments? No. Can I just thank the three of you for the report, for coming in answering our questions. It still seems very complex, and hopefully, but I'm guessing, you know, we're in a very dynamic situation at the moment, and stuff may change as well. We may get. I thought the arrangement that we got feedback on, where in fact cash was no longer, or allocating financial responsibility was no longer part of the process, actually seemed to work well, and let's hope that the government reintroduces funding in order to be able to do that while with the second wave. So on that note, thank you to everybody for their questions, and to our people in the hot seat, and you have our best wishes for helping to cope with what's going to be a very difficult period, obviously. So thank you for that. And I'll move on to the next item on the agenda.
Thank you, everybody.
Thank you.
Bye.
Thank you. Bye.
Okay, we've got one last item on the agenda, and that's we'd really like you to endorse the Continence Services report that a small group of us produced. It was circulated in advance because I knew we were going to be very busy at today's meeting, but happy to answer any quick questions or comments. Sue, yes. Councillor Sue Alston.
Sue Auckland's had to go, so you're all right now. It was just a very, very quick comment. I mean, I think the working group's done a good job there, but I just think it would be really nice. I know you've put in a bit about talking to new mums, which obviously is my day job anyway, about it. But it's also women in particular as they get older, and I think it's about sort of making people aware that they should be able to ask, and that sometimes things can be done. It's not just something you have to put up with, and just to make it more acceptable and know that they can go and talk to their GP or local practice nurse or somebody about it, and make it a more acceptable thing to ask about, really.
Thank you, Sue. Angela, Councillor Agencio.
Can I answer that? Because I was involved with the group, and we did actually have quite a lot of conversations about exactly that. Maybe we can make it more explicit in the report that we did, and we particularly talked also about how advertising certain products, it sort of puts out the message that you have to cope with it rather than do something about it that can actually sort it out. So we did actually look at a lot of the issues. So maybe we can just add something. I don't know if it's possible at this moment in time, but it is something that was discussed at length, actually.
Okay, and Emily.
I was just going to say, we've got a section there at 4.4.3, and one of the recommendations about raising awareness and tackling stigma, and we can I think we can just add a couple of sentences in there to make all that stuff more explicit quite easily, if that's what people think would work.
That's fine. You know, thank you for the feedback on that, Sue. Okay, any other questions or comments? I mean, I'd like to thank everybody who's involved in it. It has been delayed for obvious reasons because we were overtaken by COVID, but we didn't want to lose the piece of work because we felt it was a nice it was a good piece of work for Scrutiny to have done, and it was very people-centred, unlike some aspects of the services that we looked at. So, any other comments, questions? Can I ask for your agreement then that we, with that clarification, we'll add a bit more into that. So thank you for that. The other point actually, wasn't it, Emily, that there's a lot of references in the report. Sometimes when you've done stuff, it's in your mind, you think it's very clear, but going back and looking at it, I realised the references to the north of the city and so on weren't explicitly about some of the issues we wanted to raise about diversity. So we thought we might just clarify that it isn't just geography, it's actually about diversity as well, and just to make that a bit more explicit. That was in our heads, but it didn't appear. And when Emily and I chatted about that quickly, we both thought it was in the report, but it hadn't been highlighted adequately as well. So there's those two little changes we want to make. Okay, so with your silence, can I take it that you're happy to endorse that report? Okay, thank you. And thank you very much to everybody who was involved and who contributed to that. Okay. On that note then, Emily, you've still got, do you want to say anything about the next meeting, the draft work programme?
There's not really much more to add. You've got the work programme in the papers. We're working on bringing health inequalities and an update on test, trace and isolate to the next meeting in November, then primary care for the December session. If there's anything people want to add or comment on, we can factor that into the discussions.
Or any suggestions about people that we feel that we have a good contribution to make to any of those sessions, do make suggestions to Emily. Okay, any comments, questions? No, I think we're all tired by now, and which is why we usually try for shorter meetings. So just to thank everybody again for a lively meeting, lots of really good points and questions. And to confirm that the next meeting, unless something disastrous happens, well, it's happening, isn't it? But anyhow, it will be on the 11th of November at 4 o'clock. So on that note, thank you very much and goodbye.